So this is our first webinar discussion on emergency airway management. This is thanks to Gene Rogers for putting this together, and sort of a pilot discussion lecture, and we'll see how it goes. So hello to everyone out there. Okay. So in talking about airway, the spectrum goes from very simple airway maneuvers and the simple patients to very difficult airway maneuvers in difficult patients. Right now we're just showing some pictures, and you can see this could be a potentially difficult airway. And this here, obviously a difficult airway. These are all real patients that were seen. Okay. Just before we begin, we're going to start out with some basic physiology and go through some very basic airway maneuvers again, and then we'll get into more and more stepwise fashion. So I kind of arbitrarily just named them like level 1 airway maneuvers, level 2. This isn't anything written, just kind of went this way and putting together the discussion. And it's going to get more and more complicated. The more complicated the airway maneuver, the more time we'll spend on it. Not that it's going to be performed more, just because inherently it's more complicated. Okay, just a few things in the beginning. Certainly the world of the airway has changed out of the hospital as well as in the hospital, and we will keep that in mind. I'm going to repeat this slide throughout the lecture just to kind of drive the point home. Any iatrogenic, in other words, any medical-induced hypoxia cannot be tolerated as the morbidity increases, and we've seen that here locally, and we've seen that nationally, and that's a hot topic. And this is not meant to go over hot topics in detail. This is just a basic review of airway management. The oxygenation must never dip below 90% during any airway procedure ever. And again, we're going to talk about why that's important. No longer is the success deemed as getting a device in its place in airway management, but rather not inducing hypoxia. And this is out of the hospital and in the hospital, and it's forgotten sometimes in both places. Okay. Okay. The emphasis is now on proper patient selection and non-invasive techniques, as the days of the cowboys in the Wild Wild West, again, outside the hospital and inside the hospital, are pretty much over. Okay, so it's all about the oxygen. That's what we're talking about. So just real fast, we're going to talk about O2 delivery. And O2 delivery comes down to the cardiac output times the O2 content. In other words, the whole airway issue is how do you get oxygen to the tissue? And that's really what it comes down to. Don't worry about this formula, but this is the O2 delivery formula that's really everything based in the intensive care medicine and emergency department and sick people it's based upon. So O2 delivery is a factor of all these things. Cardiac output, which is stroke volume times heart rate. So if you want to increase someone's O2 delivery, you can increase their heart rate or you can increase their stroke volume. Both of those things increase the cardiac output. That's why we use pressors, norepinephrine, dobutamine, epinephrine, and so forth. That's one way of increasing O2 delivery, just increase the push of it forward. The other way, it's a factor of hemoglobin times a fudge factor times the saturation. In other words, we can increase the saturation, the pulse oximeter. If it's 80%, how do we increase the O2 delivery? We can make it 100%. Okay. Or if someone's anemic, if they have a hemoglobin of 5, we want to make their hemoglobin more than 10, we can give them blood. So all these factors, cardiac output, which is stroke volume, heart rate, hemoglobin, or O2 saturation, all this increases O2 delivery, which this is really all about. Okay. So just kind of a basic model here. Again, very much a review. You have oxygen in the alveoli, crosses over the capillary membrane of the alveoli into the hemoglobin molecule, and now it's oxygenated hemoglobin by a concentration gradient, which everything works in life. Goes around to the tissue, concentration gradient, and it goes off the hemoglobin across the capillaries into the tissue at hand. This could be a neuron, this could be a myocyte, this could be whatever, okay? That's what it's about. The gaseous form of oxygen does not significantly cross the capillary. Only the oxygen bound to the hemoglobin significantly crosses the capillary. And that's important because once you maximize someone's hemoglobin and once you maximize their saturation, giving them more and more oxygen does very little. This is an oxygen saturation curve, and this is it as far as the boring stuff goes. But you can see this is the gaseous form of oxygen, and this is the saturation. The reason we use 90% saturation is so important because once the pulse ox, once your gaseous form of PaO2, your gaseous oxygen, once it goes down, 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 and your pulse ox hits 90 right in there, once you lose a little more oxygen, your saturation goes down abruptly. That's why the 90% is so key, because that's a slippery slope when you're at 90, because once you drop below 90, you're going to drop quickly. Okay, this is, again, so basic stuff here, but it's good stuff. So who needs airway management? Anyone in respiratory failure? It's a good way to think of respiratory failure as hypoxic respiratory failure or ventilatory. Who gets hypoxic respiratory failure? Basically anyone with fluid in their alveoli, whether it's pus or water or pneumonia or CHF, okay? Or it could be a pulmonary contusion, blood in our alveoli. Ventilatory failure, COPD are classically, they're not ventilating. And then you can get loss of protective airway reflexes, head injury, airway obstructions, okay? So this falls more into a hypoxic respiratory failure. You can see there's fluid in the alveoli. This is going to prevent the oxygenation. The oxygen was not going to get down to the alveoli, so it's never going to cross the alveolar capillaries and get into the desaturated hemoglobin. So you're just going to be shunting venous blood back into the arterial system because you're not able to get it across the alveoli. Okay, and that's kind of a fluid-filled alveoli. Diseased alveoli, who gets the COPDers, they basically lose their alveoli. You can see it's just destroyed. So they're not going to be able to oxygenate as much because they don't have as much surface area. And then diseased airway, asthmatic. Classically, asthmatics, a very inflamed airway. You're not be able to pump the air through and so forth. And then, of course, you can have a vessel problem where the oxygen is in the alveoli, but you can't get the blood to it from a pulmonary embolus, or so to speak. These are just basic reviews of why someone's hypoxic. And remember, you need the car to transport the oxygen molecule. So if someone's anemic, you can't get as much O2 delivery because you don't have the hemoglobin to carry it around. Okay. Again, just basic stuff. Here's the alveoli filled with oxygen, the desaturated hemoglobin on the pulmonary capillary picking up some oxygen going around. Okay. So I don't know if everyone can see this. A bad picture, I apologize. So when someone has, when you go up to someone, there's an airway issue, and there's signs of an airway obstruction. What would some signs of an airway obstruction be, just in general? Just choking or stridor or snoring. You have to think, reverse what you can reverse first, and always do those maneuvers first. Altered mental status, dextrose, Narcan, airway. Lift up the hyoid. Well, who cares if you lift up the hyoid? Well, it's important because the base of the tongue is attached to the hyoid. So if you lift the hyoid anteriorly, you're going to free up that obstruction that's caused by the base of the tongue. And you can see it here, the nasopharynx. This is the hard palate and the soft palate, and the oral pharynx. And here's the tongue up where it should be, and here's where it's not should be. If you try that and it doesn't work, you can try some airway maneuvers. Oops, that didn't sound. Uh-oh. Try that again. Oh, there we go. So this is a family show, as you'll see through this. Okay. So here's the situation. You walk up to a person and they have an airway issue. This could be you're on an airplane, wherever. And the first maneuver you're going to do is you're going to try to lift up that hyoid bone. And we have Corey here who's going to demonstrate on the mannequin just real fast. Yeah, of just walking up to that person and just doing a basic airway maneuver to.
Assuming the ever-present C-spine injury is not a concern, obviously you're going to do a head tilt, chin lift. So you're going to tilt the head slightly and lift from the angle of the mandible and just pull the hyoid, as Dr. Lafferty was referring to, off the back of the throat. And that will allow for a natural airway to exist. Obviously, that takes both hands, and it takes one rescuer out of the what's going on otherwise. So you need somebody else to be able to ventilate or do whatever until you can get enough hands on board.
Excellent, excellent. And that's the most basic airway maneuver. And this is often forgotten, and it's something we don't want to forget. Okay.
Level 2.
Okay. Okay. So arbitrarily broke these down into basic airway maneuvers into more complex. So there's nothing in the literature about level 1, level 2. This is just for your entertainment, so to speak. Okay. Okay. So here, if this person could not, if this did not alleviate the upper air obstruction, you're still not able to ventilate this patient. They're not ventilating themselves. There's still noise in the airway, whether it's snoring, stridor, what have you. Then you still have to assume, hey, the base of that tongue is still blocking their pharynx. In other words, the posterior part of the tongue is still against the anterior part of the pharyngeal wall. I tried a chin lift, jaw thrust. I can't get it. I can't get it up out of the way. Then there's some conduits that you want to put in place. And this is just a sagittal CAT scan. Plus, I was bored last night, and this is a nasal trumpet showing how it would work down the nasopharynx, right down where it goes between the base of the tongue and the anterior pharyngeal wall. It's actually a pretty nice visual of it. And the same thing here on an oral airway. You go down the oral pharynx using the OPA. Same thing, going on the base of the tongue, and it's just making a conduit between the base of the tongue and the anterior airway there. Actually, and do you want to demonstrate that, Corey, if you don't mind? Okay. And there's just one more for you later. So.
All right, OPA, NPA. Obviously, which you choose to use will largely be dependent upon the responsiveness of the patient. If the patient has no gag reflex, is totally unresponsive, of course you can go with the OPA. If gag reflex is intact or some degree of responsiveness is there, they won't tolerate an OPA. NPA is a great device because most people can't tolerate that. Obviously, you know the measurement tools, nose to ear, corner of the mouth to ear. Get as close to the right size as you can. If you're going to use the NPA, a little bit of lubrication goes a long way. I'm kind of a stickler for detail, so personally, I kind of shine a light down the nostrils to see which one is naturally more dilated, and I usually pick the side that's wide open. You know, why drive through a narrow tube if you can drive through a big tube? So I just quickly look down there if I had a chance, and I preferentially pick the one that's widely dilated, just for ease of placement. Ordinarily, most people pick the right nares initially, just because of the bevel, which technically doesn't really matter. But anyway, of course, it's lubricated. Just slide it until the flange hits the base of the nair, and then ventilate as you ordinarily would, BVM, whatever you're going to be doing. If you're going to use the OPA, again, this is probably a little bit small for this patient. It's somewhat controversial on the way you place it anymore. The old spin as you go down has become a little bit more controversial than it used to be, largely because you can tend to have the tip of the airway push the base of the tongue further down into the airway, further obstructing it. If you have the ability to do it, get some sort of a straight tool, tongue depressor, laryngoscope blade, something, and just go in and lift the tongue and then place the airway naturally. And that way you know the base of the tongue, if this is the tongue, if you lift it up and sit this underneath it, you know the tongue is lying on the airway and you haven't jammed it in there further. So if you have it available, some sort of a stiff blade, a tongue blade works fine. Just lift it up, place the airway, and then let the tongue lay back down on top of the airway. And again, you resume your normal, whatever ventilation technique you're choosing to use it. Okay?
Excellent. And it's a good point. If it's not the correct size, you could actually push the base of the tongue and actually make the airway obstruction even larger. So. Okay. So now we'll talk about, we tried these other modalities and things aren't working too well. We'll talk about non-invasive pressure, positive pressure ventilation. And for pre-hospital patients, severe respiratory distress, this modality may provide a therapeutic option and potentially averting a more invasive airway. The National Association of Emergency Medicine, of EMS physicians states that this type of an airway, a non-invasive positive pressure ventilatory airway, such as a CPAP, BiPAP, it's an important pre-hospital treatment modality for acute dyspnea. And the studies have shown, we'll just go over a couple of them, that can alleviate endotracheal intubation, which has its inherent risk acutely as well as downstream as far as in the hospital goes. So, okay, non-invasive pressure, positive pressure ventilation is a form of mechanical ventilatory support delivered to a face or nasal mask without the use of an endotracheal tube or another invasive patient. The patient has to be awake for this and have their airway reflexes intact for this in general. Obviously, this type of patient, you don't want to drive any vomitus into the airway because that's going to create a setup for aspiration, which has its sequelae, which we'll talk about in a little bit. Now, how does a CPAP, BiPAP improve oxygenation? Because remember, we're talking about oxygenation right now. It reduces the work of breathing and improves pulmonary compliance. It recruits atelectic alveoli. In other words, some alveoli, instead of the nice bubble form like this, are sometimes collapsed. And if you have a positive pressure in your airway, such as PEEP or whatever, or CPAP, BiPAP, it actually forces them open, and now you have more surface area to have oxygenation through the alveolar capillary, or the pulmonary capillary, to have oxygen transport. So it recruits those atelectic, which means collapsed airways, and it makes them open, makes them stiff and bubbly, okay? That's probably the major way. The other way, especially in pulmonary edema patients, which most of the literature comes from, it increases the hydrostatic pressure, shifting the edema fluid from into or out of the alveoli into the lymphatics channel. So it's actually just a forward push, pushing some fluid out, okay? It actually increases intrathoracic pressure, which decreases venous return, which decreases preload, which helps in CHF patients as well. Two types, and again, this is a very basic review, and this is a stepwise fashion, so bear with for right now. There's two types. There's a continuous, and there's a bi-level, a CPAP and a BiPAP, okay? CPAP applies uniform pressure, and BiPAP alternates with different levels. In other words, an I and an E pressure, and so forth. I don't want to go literature heavy here, but there's some nice studies in BiPAP, and that's why it's adopted in the last number of years, pre-hospital as well as in-hospital. In this systemic review of meta-analysis, in other words, they looked at different studies and took all the data from all the studies, put it together, and created a new study. There's many inherent flaws when you do a meta-analysis study. However, it is a good way of just generally looking at the data. It's not as good as a prospective double-blind study and so forth, but it's kind of on your way there. But anyway, CHF patients, they found that this non-invasive positive pressure ventilation was associated with a reduced need for endotracheal intubation and a decreased mortality compared with conventional therapy, okay? Another meta-analysis shows that it was associated with a reduced need for endotracheal intubation, ventilation, mechanical ventilation, and mortality. Okay, there was a prospective control trial in France, and basically what they did is they took 176 patients and they broke them down to, they treated them early BiPAP, where they kind of did conventional therapy, wasn't working, and then did BiPAP. And they just looked at the results, and they found that the pre-hospital or the emergency department ET tubes was less frequent in the early BiPAP patients than in the conventional, then later BiPAP. So if you're going to use it early. Okay. The general indication for this type of airway modality is someone who has, again, intact airway reflexes in a mental status that is normal, okay? The literature is focused historically on CHF patients with pretty good results. I think all of us anecdotally realize that, you know, we used to put more invasive airways in CHF patients, and we're seeing, along with medical therapy, the CPAP, BiPAP improving our outcomes. And some of these patients, you know, not too long ago, you would think are going to be intubated, no doubt. Not only the literature bores that they won't be, anecdotal evidence certainly has shown that they can get through it and get them over the hump. Okay. Comparison study of this type of modality with conventional therapy suggests improved oxygenation and reduced need for pre-hospital or emergency department intubation. And you know, in general, you'd rather not place invasive airways in patients. It leads to nosocomial infections and other complications. So, okay. Okay. So I kind of left this as, you could say supraglottic airways in general, but I think now we're using solely the i-gel, with I know the results locally have been very good, and nationally they've been very good. So the i-gel is a very good device. Has everyone, I'm just talking, does everyone use the i-gel here? Has everyone used it in a real person? Or anyone used it? Okay, all right. You've used it, okay. So someone has used it, okay. This was just a very recent study, actually, where they looked at 2,000 patients receiving the i-gel. And they just basically looked, you know, is there any complications? How easy was it to use? This actually didn't come out too long ago. And what they found, in a nutshell, it's extremely easy to use. And part of the reason they think it's easy to use is there's no air. It's this elastic gel material that goes in. So you're not dealing with the air leak, a big thing. It's very easy to insert. Less than 5% complication. The rate of placing it was very easy. And they come up with some risk factors for possible, you know, things to think about. Anyone with mandibular subluxation, poor dentition, older age. However, these patients would be difficult airways in any device. So the i-gel certainly is here, and I think it's here to stay. Okay, we just talked about this, no air, easy to use. And there's kind of a picture of it on a sagittal cartoon of a patient there, and you can see just goes through the oral airway, then the pharyngeal airway, and it actually goes on the other side of the epiglottis, and there's a gastric port where you can actually place a nasal gastric tube through the port, and you can actually get some gastric drainage, which is important too. But those studies aren't really looking good. There's nothing perspective on that right now. Right now, it's more the ease of use, so to speak. There was a mannequin study that actually looked at the i-gel versus another supraglottic LMA, as well as an endotracheal tube. And the i-gel, and again, this was not a classic study that you like to hang your hat on, but these studies are important to look at. And it was about 50% faster to use this than conventional direct laryngoscopy and LMAs. So that is a good thing. Oh, I'm sorry. Do you mind demonstrating that, Corey?
I'll try.
I'm putting Corey on the spot, and it's difficult to put a i-gel in a mannequin.
Yeah.
As
I to use this on the. Sure. All right, we'll try. I'm not sure how well this will work.
And by the way, this is our supraglottic device of our local area here. So.
They have some very good online teaching aids for this from the manufacturers. If you haven't looked at those, I would recommend it. You're supposed to use your little tray here for your receptacle for your lubricant. You lubricate the posterior portion of the device. Again, you can use the old classic grab the lower jaw or just simply lift up. I'm old school when it comes to that. I kind of grab, and I'm not sure how well this is going to work. We'll try to keep the lower jaw and the tongue up out of the way. I'm grabbing the tongue. And next is the long way. Not quite this hard, but insert it until it goes back. You should feel a distinct pop or a settling of the end of the tube. It should be approximately where the bite block is on this. Unfortunately, right now, you have to use tape to secure this tube, and you need some downward pressure when you tape it in place. In other words, when you do a wraparound, go around the head, however you do it, when you finally end up your taping, have a little bit of a downward pressure so it will keep it seated at the airway. Don't allow it to migrate north. That's the one big problem you can have with this airway, especially if you don't anchor it. It'll tend to migrate north, and you're going to lose an effective airway. So make sure it's taped and secured, and then of course you ventilate Auscultate the breath sounds, make sure you're getting adequate ventilation, look for good chest rise and fall, and then you can put on your capnography or whatever else you need to on this. The good news is, I don't know if they're immediately available, but very soon, the newest eye gels coming out have a contraption to secure it as part of the device. And it will be on there, and you won't have to use tape and other stuff. Are they out yet, Samantha?
Not yet.
I don't think we have them yet, but they're supposed to be immediately available, so in the very near future.
Quick question, is there anything wrong with cutting off the tubing of just O2 tubing, non-repeat?
Whatever works, I'm good with. Personally, I don't care. If it does the job and it keeps a little bit of downward pressure on there, I personally don't care.
From experience, tape doesn't typically keep it down. You need the self-adhesive tape that sticks to
The
itself.
Covan?
Yeah, that works
Yeah.
better.
Fire guys, clove hitch in the open, right? And then, I'm not sure this is what I've seen done a couple times. Yes, no?
Yeah, some people use nasal
This is
cannulas and
plastic
just
on
cinch them
plastic.
down, whatever.
So plastic on plastic, right, is not going to, see if you can pull that out with me.
Yeah, it's stable. Whatever keeps it where it's supposed to be.
You probably don't want to do that.
Yeah, don't put too much lasso pressure on her. You don't want ligature marks when you get to the hospital. And again, once it's in there, you ventilate as normal. We tell our people
It's souvenir.
to migrate to the caravan as quickly as possible for two reasons. Number one, it avails that person, the airway person, to do other things, and it helps control unintentional hyperventilation. We all know hyperventilation is not a good thing, so we transition as quickly as we can to the caravan so it'll control unnecessary hyperventilation and overventilation.
I know that in using this in the field, if you have a very wet airway, this is not a good tool to use. You want to see properly.
You mean more like a gastric content wet airway or a COP or a CHF type wet airway?
No gastric content.
So you mean wet airway right at the glottic opening?
If it's already a wet airway,
Hundred 61.
very difficult to see.
Breathing difficulty, 669,
It does kind of beg. Anytime you use a blind insertion device airway, you should really toilet that airway good before you stick anything in there. If you know there's a big puddle of goo back there, don't just jam this right into the goo. That's just not smart. Back in the King Tube days, we had a big puddle of goo. You stick it in there, you got a balloon here, a balloon here. You just entrapped all that goo, and it's aimed right into the bronchioles. I mean, that's just poor management. So make sure you grossly suction the patient out, log roll them, let it drain out, do whatever you need to do. So at least at this moment, that posterior pharynx is clear, and stick this in there. And then if you have time, of course, put in a gastric tube as well. Any other questions or comments?
There was one, Corey, on the internet side. It says, does anybody have issues with vomit traveling up the eye gel? It says without an NG tube inserted.
It's been reported, and again, that's vomit that's probably already there, because once this is in place, it relatively well protects the airway. Because think about it, the glottic opening is on the ceiling. As somebody who's supine, the glottic opening is on the roof, the ceiling. This goes up and protects that opening.
Court, you can right there.
Okay. Again, the trough of the gastric content will come underneath it and come up through the esophagus. So this kind of holds it up, again, on the ceiling, and you have a natural trough that still exists underneath. Now, if it's a tiny person and the airway obstructs that whole thing, you could develop a positive pressure here, where it could breach this seal and go into the glottic opening. But in most patients, there will still be a natural trough underneath, so you could still conceivably use a yank hour and suction stuff that's coming up and around the tube, and the airway is still relatively protected. The problem is if you insert this right into a big puddle of stuff, and you trap it, and then you entrain it right into the airways. That's just not good. So that brief 5 or 10 seconds before you stick this in there, make sure you got a nice, clean posterior pharynx, so you're not basically just kind of ushering in all that stuff right into the airway. You've almost defeated the whole purpose. Good enough?
Yeah, and a good point to, anytime you stick an invasive airway in someone, to make sure you have some kind of gastric draining device in there as well. And the IGL does that very well.
Okay. Daddy, this is level 5.
Okay. So we're just going to talk about endotracheal intubation and some drug-induced, or what do you call it, DAI or RSI or whatever they're calling it today. We're going to spend a little more time on this for the only reason it's more complex, and that's the only reason. This is going to be the least used modality, but it's going to also be the highest risk, and because it's most complex and least used, this is a skill that we think we all need to stay on top of. Okay, this comes from basically Sept, the American College of Emergency Physicians, the American College of Surgeons, the Committee on Trauma, and the National Association of EMS Physicians 2011, basically position statements on this topic. One of the things that says EMS providers performing RSI should possess training, knowledge, experience, and technique, as well as the pharmacological aids. This is right from the position statement. And basically, without going into this in detail, everything is about supervision, training, education, ongoing training, education, knowing the pharmacology, knowing patient selection to use this, knowing when to use it, and make sure we have a good QA, performance review committee, and so forth. And that's their statement. And based on that, we will move forward. And again, some of the highlights I just talked about: patient selection is crucial, and sometimes that's not the easiest thing to do in the world. It's not the easiest thing to do in the emergency department. When do you move up a step, a level 1, so to speak, to a 2 to 3? They're a little easier, but when do you go from a 3 to a 4 to a 5, so to speak? And it's not everything's black and white, and sometimes it's a challenge. Okay. So anecdotal reports suggest that many EMS systems do not regularly examine the quality of airway management in general, whether it's a supraglottic airway, more invasive airway than that, whether it's a CPAP, BiPAP. Studies have shown up to 25% of the endotracheal tube placements in the field were in the wrong hole, and that's unacceptable, completely unacceptable anywhere. Extrapolating known techniques and procedures that are intuitive and evidence-based from the emergency department to the field often makes sense, and it's been often what's been done over the years. There's been techniques and modalities over the years that are born in pre-hospital setting and come to the emergency department. We just had Todd Coulter in our emergency department training our physicians and physician assistants in the EZ-IO, and that's not something that was born in the emergency department. That was born in the field. So it is dynamic. Things go in flux from the hospital to the pre-hospital and pre-hospital to the hospital. However, when you start getting into some advanced procedures, the same quality training, education that occurs in a hospital, it has to be implemented in the pre-hospital.
RSI in a nutshell.
So, should be a little too much free time at home, huh? So just because we can doesn't mean that we should do something. We need to assure competency and proficiency of those times. We need very high risk, low frequency skills, and that's what this is. This is a high risk, low frequency skill. This is why the police don't firing ranges, I imagine, so forth. I was just reading some comments in the literature and the internet. I know, so there's different opinions on this. So let's just kind of jump into it. So what is RSI, DI, whatever? It's basically taking and I'm going to paraphrase some of these slides from it. It's basically taking an awake patient with the assumption they just left McDonald's and they have their Big Mac, supersized fries, and milkshake in them, and they're having an airway issue, and you need to place an invasive airway in them, and you're assuming that their stomach is full, obviously, and you need to take them from a somewhat awake or awake state to immediate unconsciousness. In other words, immediate general anesthesia. And typically in general anesthesia, the agents used, the drugs are titrated into these patients. In RSI, rapid sequence intubation, it's a fixed amount of drugs pushed. And basically the best way to think about it is 2 drugs, an induction agent, make them sleepy, and then a paralytic agent, so they don't move. And that's it, and with the assumption their stomach's full. So you're assuming their stomach's full, so you don't want to do anything to increase or cause any gastric dilation. So you're assuming their stomach's full and you have 2 drugs to do. That's really it in a nutshell. Okay. Okay. And then there's adjunctive pharmacological agents to decrease aspiration and hypoxia. And again, it's taking a breathing patient in acute unconsciousness. Aspiration is one of the no-nos. Just like hypoxia is a no-no, we should not tolerate aspiration. Just like Corey was saying, if there's a puddle of goo in the pharynx, don't stick a device no matter what the device is and force it down with positive pressure ventilation into the lungs. That's going to cause a nasty pneumonitis, and their morbidity is going to skyrocket in the hospital stay. So just because you get them in the hospital doesn't mean, hey, this is a good thing, we're here, we're done. We don't want to force that vomitous material into the lungs to get a nasty pneumonitis, and their morbidity increases. Okay. Okay. And basically, patients who do aspirate, they go on to severe hypoxemia, ARDS, pneumonia, pulmonary edema, all kinds of bad things. The gastric contents in the lungs is almost similar to a wartime chlorine and phosphine gas exposure, essentially ARDS. If you survive a cardiac arrest and aspirate, your morbidity and mortality increase greatly in the next 1 to few days, and you get a hemorrhagic pneumonitis that starts about 6 hours later. So it's very bad. You can see here on oh, this isn't working. Sorry, man, it's not working. You can see this kind of like a normal chest X-ray here. The lungs are black because it's air, so there's nothing stopping the gamma or the X-ray beam. You can see a person who aspirated with ARDS. Those alveoli are filled with fluid, and if they're filled with fluid, they're not going to be filled with oxygen, and that patient's going to be hypoxic, and then they're going to go on ARDS, sepsis, and SIRS, and all that kind of bad stuff. This is a microscopic cut or a histopathological slide, and normal alveoli shouldn't have all this goo, so to speak, in the alveolar sac. It should all be like this, clear. And that's hard to get over on a patient. That's hard to get over when you have it at that level. Okay. Again, the repeated slide, any iatrogenic induced hypoxia cannot be tolerated. O2 sat drops below 90, do something about it, and it's just the way it is. Okay. Studies shown that if people who experience aspiration upon tracheal intubation, more than a third experience significant morbidity. Risk factors: infants, recent oral take, trauma, pregnancy, GERD, narcotic anticholinergic, obesity. Basically, any of our patients that present acutely are at risk for aspiration. Okay. Okay. The major risk of inducing someone into a coma-like state is that you're not going to get the airway and you just paralyze them. That's the major risk of RSI. In saying that, there's adjuncts to help us alleviate that. Okay. A couple of patients you don't want to do RSI on, someone who has a partial airway obstruction, and this may even be for a supraglottic airway. Someone who is depending on their tone. It could be, well, like this patient here with angioedema, or someone, a burn patient. They're relying on their airway tone to keep their orifice open. If you decrease that tone by giving a pharmacological agent that relaxes muscular tone, now what little tone they had keeping everything open, you take away, you might have caused a partial airway obstruction into a complete airway obstruction. And that's no time to play cowboy, no doubt about it. So the partial airway obstruction, if they are moving air, that's a good time to get these patients to the hospital, because then there's fiber optic equipment, there's personnel, there's all kinds of other resources to go for. Certainly one of the worst situations to be in is a partial airway obstruction. And I think it's where all of us earn our money. And sometimes it's the things we don't do as opposed to do really helps that patient. And this is one of those situations. Okay? Okay. So why is he saying uh-oh, Corey? Corey, my Corey, not you. You might be saying no. So the San Diego paramedic RSI study was the classic study that changed the thinking of everyone in airway management. And it was a good thing it happened, because now we're using endotracheal intubation less in the field. Again, it's in a pocket. We need to know about it, when to use it, just like a police officer when a shooting. However, it really opened our eyes. Because certainly, I think when all of us trained, I think I can speak for most people in here, success was get the tube in. It didn't matter, whatever the device was, it didn't matter they were blue and cyanotic on the way. We got it in, we were like, yeah, we're good. And that thinking bore out in these studies, and certainly the classic study was the San Diego RSI, traumatic brain injury, low Glasgow scoma, less than 8 study in 2003. And I think it opened everyone's eyes up. And again, not just pre-hospital, but hospital setting as well. You know, what we're doing and what we have to be looking for. So what they found is these were mostly head injury patients, RSI in the field, and they looked at the times and so forth that the paramedics were doing, RSI, the success rate, hypoxic times, and so forth. They found out that the median or the average duration of desaturation was 160 seconds, or almost 3 minutes. So we know neurons stay alive for 4 to 6 minutes, and these are already compromised brains because their Glasgow coma scales of 8 and less, and they're inducing essentially hypoxia for 3 minutes on average. Not good. That's not the scary thing of this study, though, I don't think. In 84% of these cases, the paramedic described the procedure as easy. And again, you have to extrapolate, but you have to think of at least, you know, all of our training, most of us in here is like, hey, got it in, got it in. Well, yeah, you got it in, but the authors concluded that until an effective practice model regarding proper pre-oxygenation is developed and sound education and training, that this may not be justified in the field. So the scary thing is that when I read this study and I read the reviews and go over it again, it's not necessarily, okay, this happened, but most of the time this happened, the practitioner thought it was easy. Didn't even recognize the hypoxia. Okay, and there's more studies like this, and there's studies on the other side as well. A 2010 study evaluated almost 900 consecutive trauma patients who had pre-hospital endotracheal intubation, either RSI, non-RSI. Use of pre-hospital RSI was not associated with improved survival. Again, a retrospective analysis explored the impact of hypoxia and hyperventilation on outcome. Bad stuff happens with hyperventilation, as of course an e-patient, basically profound desaturations during RSI and hypoxia after intubation were associated with higher mortality than match controls. Overall mortality was 41% for trial patients, RSI, versus 22% for match controls, no RSI. Authors conclude hyperventilation and severe hypoxia during paramedic RSI are associated with increased mortality, as it would be with an increased mortality in the hospital if we hyperventilate anyone and allow hypoxia to go on. Again, the monkey skill of putting the device where it needs to be is not where it's at. It's the education, training, and recognition of the pathophysiology and the awareness of the sequelae of hypoxia is the whole key to all this, okay? And all of our, and this has been a good thing, it's opened our eyes. There's another study here, and I'm just not going to go. I'm not going to go into these in too detail, but they looked at physician oversight on a pre-hospital RSI program, and basically, when the physician oversight, and it was nothing the physician was doing per se, it was just bulked up training, bulked up education, bulked up practice, and so forth. They improved. Okay. Okay. So, in doing this procedure or any invasive airway procedure, you know, you want to look at pre-oxygenation, cardiac monitoring. I can't imagine not taking care of someone's airway without suction. I don't know, that's not talked about a lot, but you have to have suction right by you when you take care of an airway, because if you don't have a good view, forget it. Now you're really doing a patient some possible harm. Okay. Heart monitor, you can get dysarrhythmias when you stick any device into someone's pharynx, whether it's a supraglottic airway, whether it's just suctioning someone, whether it's a Yankower, you know, you can cause dysarrhythmias on a monitor. Pulse oximeter decreases the hypoxic times in one study by 12%. Obviously, you need a pulse oximeter on someone when you do this procedure. Again, same slide. We must not induce hypoxia on any procedure, okay? We just talked about suction. One of the things is aligning the lines. okay? And let's talk about, there's a sagittal of the airway. Let's talk about these lines. You have an oral line or an oral access. You have a pharyngeal, let me see, this way, kind of perpendicular to the bed or the floor, wherever you're at. You have a pharyngeal line, almost, I guess at a 45, and then you have a laryngeal line. And the whole thing is using the old-fashioned way, which I call it now the direct laryngoscopy, the metal blade, is part of the challenge is you have to line up the line. So you have to bring that oral line closer to the pharyngeal line and bring that pharyngeal line closer to the laryngeal line to see the golden ticket or the vocal cords, okay? And that's where a lot of training comes in, okay? Children, you don't want to extend the neck as much. That's basically, okay. So why do we pre-oxygenate anyone before drug-assisted intubation or RSI? This is where, again, it always comes down to the oxygenation. This is where many people fail, pre-hospital, out of hospital. If you don't fill up the alveoli with oxygen, you're not going to have much apnea time, and we're creating apnea. And what you're really doing, and there's a depiction there, and again, the oxygenation is everything from our O2 delivery formula. What you're really doing is you are washing out the nitrogen. So if you look at that alveoli again, it's filled with oxygen. Normally it's how much oxygen is in the alveoli. It's the same amount in the room because it's just a conduit, so it's 21%, right? So it's about 78%, I think, nitrogen. What you're really doing is you're displacing the nitrogen or nitrogen washout during your pre-oxygenation phase, and you're filling with oxygen. Now you have an oxygen reservoir. So when the patient becomes apneic or there's some difficulty that happens for whatever reason, we don't have that hypoxia time, which is so dangerous. And it's typically accomplished, and you have to look at some of these times and take them in just 3 minutes of a bag valve over the mouth, no positive pressure ventilation, because they just came from McDonald's and that Big Mac is ready to go. So you're just allowing passive nitrogen washout. The seal is everything here because it's a one-way valve and you want it out, and that's what you're doing. So typically 3 minutes, and you can create up to a 6-minute apneic time. That's really in the best case scenario of healthy subjects. You're probably looking up to 3 minutes though, even if you do 1 minute. Some studies show 8 tidal volume breaths by the patient, which is deep breaths. You can get up to 3 minutes of apneic time. Okay. Okay. We're almost ready for a break too, guys. So, which one is it?
Read 1048 there, ask Dr. Lafferty.
Oh, ask Dr. Lafferty what he recommends if you roll up on a patient that needs an airway, have an eye gel, but not suction device, insert or not. What does that mean? You roll up on a patient that needs an airway. Okay, you roll up, so you go to the patient, have an eye gel, but not suction device. Do you insert or not? Well, I'll share this with Corey, but if the patient needs an airway and are hypoxic, certainly you can roll them over if it's not a C-spine issue and try to drain them that way passively. Ideally, though, in my opinion, you shouldn't go up as a provider, as an airway expert, which we all are, as paramedics and physicians. You shouldn't go up there without suction, to be honest. I've yet to approach an airway without suction. Now, we're spoiled in a hospital. I have personnel around, put the bed up, it's done, do this, spoiled. In saying that, though, I would not, I think it would be challenging to go up to a patient without suction. So without a cervical issue, I'd roll them over to get it out, and then you have to do what you have to do. So.
No, I totally agree. A log roll is fine for gross contamination if you don't have suction, but I agree with Dr. Lafferty. We need to change the way we approach patients. The suction is usually one of the last things that we consider, and again, I mean, how many times can you say it? You really need to have it. When you need it right now, not 30 seconds from now, not a minute from now. So I agree.
In relation to that, you want to make sure you put the gastric tubing in the eye gel before you start it,
Okay.
just in case your airway does get compromised with vomit or gastric content.
Excellent. And I don't know if everyone heard that, but The gastric tube should be placed in the eye gel before inserting it, just to deflate the gastric contents of the patient. That's an excellent point. Good. Okay, we're almost ready to take a break, guys. So we talked about this. Now we fill up the alveoli with the oxygen. That way we don't have to create positive pressure ventilation. If you see someone on drug-assisted or RSI, if you see them bagging a patient, they better only be doing it because their pulse ox is less than 90 and it's falling off that oxygen curve we talked about, that slippery slope where they really drop. If you're doing it and they're above 90, they're doing the technique wrong and they're just increasing the chance of aspiration through gastric distension.
Pretty much the way we just make sure we're on the same page here when we do our SI training and stuff. We want our SpO2 at 90% and above. And if we are RSI them, pretty much just doing the nitrogen washout and no bagging. Now, if they do drop below 90%, then yes, we need to assist. And
Bingo, home run, grand slam, that's it.
Right.
And it's very hard, I find, now, I've been doing it so it's second nature for myself, but it's very difficult, and this is all I do, I write on this, but it's very difficult to take a mask with a bag, it's begging you to squeeze it in an airway and not do it. I guess it's like getting in a fast car and not really going faster. I don't know, but that's the dealio. Good.
Look, Lafferty. At that moment in time, I would recommend personally two things, and again, this applies more to the pre-hospital environment. If a patient is not in cardiac arrest and is not hypotense, keep their head up at least 10 to 30 degrees. You're allowing gravity to keep all the goo in the stomach. So don't lay these people flat. You're asking for stuff to pour out of the stomach into the hypopharynx. Secondly, have a cannula on the patient and delivering high flow O2 during this entire process. Because you're delivering more oxygen, regardless of what else you're doing, you're introducing a high flow of O2 in the airway itself. And either passively or actively, you're gonna, all the studies prove that you're gonna increase their SpO2 at least some.
Corey's mentioning a study that was just published, and it was out of Thomas Jefferson University in Philadelphia, which is not as good as Temple University in Philadelphia, obviously, but hello Temple, I did mention that, but what he's saying is the emergency physician out of Jefferson showed that putting a nasal cannula oxygenation on and then the bag on and then actually tilting it up, and I'm not sure if it was 10 or 30 degrees, somewhere in there, you actually decrease the hypoxic time. And it was a pretty interesting study. I never thought about that, but it makes sense. So that's something you can do while you're setting everything up. You know, just if you have time, and everything's, you know, sometimes you have time to do this and sometimes you don't, but you should adhere as much as possible. So,
yeah, we get spoiled just because we're so used to, back in the olden days, the vast majority of our intubations were in cardiac arrest patients. So we were just used to having patients flat. And we kind of, that spilled over into non-cardiac arrest intubations just because that's the way we did it. Well, if you think about it, it doesn't make sense. Again, unless they're in such a hypotense state, you can't afford to lift their head a little bit. Lift their head a little bit. Number one, if you're sitting in the back of the ambulance and the stretcher's here, they're right there where you can work. You're not down here trying to do this. And it allows gravity to keep all that fluid in their stomach because it's lower than their airway is now. So it makes perfect sense. Don't lay these people flat unless they're in cardiac arrest or they're just not perfusing adequately to be able to lift the head off the bed.
absolutely. Again, that was a study that just came out from Philly. Okay. The only positive pressure that should be applied is if the pulse ox drops below 90. Okay. This is just showing back in the day about cricoid pressure. That's taken out of RSI now, or endotracheal tube placement. Why is it? Basically because they did MRI studies, cadaver studies, and it turns out that the trachea or the laryngeal rings do not sit on top of the esophagus. The esophagus is often to the left of it, so it's not really doing anything, and it's actually impeding airflow to the patient. So RSI, so cricoid pressure is gone. Okay, just like, you know, a lot of things over the years, they come and go. I'm not going to worry about sympathetic activity right now. This is a point we can take a break, or we can finish the lecture. What's the vote here?
Good.
Finish it, you think? Okay, all right, we're going to keep going. Okay, so we're about halfway done through the drug-assisted or RSI. So let's move on to a couple other things.
Sedation only, man. Sedation only.
Okay. Okay, so the argument for sedation only without paralytics makes logical sense because you're not paralyzing someone and you're not potentially losing their airway when a paralyzed patient, which can be scary. But it really can't be scary, only if there's a partial air obstruction because of the conduits, the head positioning and so forth. Because you can always bag someone, okay? You don't want to, but you can. And the agents used, remember only 2 drugs, induction agent, paralytic agent. They're short, they're less than 10 minutes. They're short-acting agents, okay? So anyway, the bottom line is that the studies show that there was less success, higher aspiration, sedation only with paralytics. And these are older studies, but they've been repeated over the years. This is an older study, 1999, they looked at sedation without paralytics. And the non-paralyzed group, 15% of aspirations, 28% experienced airway trauma. Mortality rate was 3%. None of these difficulties were found in the paralytic group, sedation plus paralytic. Okay, induction phase, you want rapid sleepiness. That's what you want. There was a time in Philly, just if you paralyze someone without sedation, it's kind of mean. There was a few traumas going on. Someone's upstairs. Someone made a phone call, nurse, and they got the medication wrong. They wanted to sedate this patient, chemical restraints, and CAT scan. And the nurse, I heard it wrong, or it was given wrong, who knows, but ended up getting a long-acting, non-depolarizing paralytic agent, Pavlon, to sedate the patient, and a code was called, and so you don't want to do that. Okay, so the ideal drugs, quick onset and short half-life, that's it. All these sedatives, whether it's alcohol, propofol, barbiturates back in the day, benzodiazepines, etomidate, all of them except ketamine, which is, works differently, works on a GABA receptor in the brain. And basically when you bind to that receptor, pretend this is a neuron, it opens up and it lets chloride into the cell, which makes the resting state, more negative, so it hyperpolarizes the cell, so it's less apt to fire. So you're basically putting the brain to sleep. Some bind more quickly, some bind more strongly, and that's where what's going on. Okay. Short and quick. Okay. So what's the gold standard right now? Etomidate is by far the gold standard. It's short, it's quick, it's been around since the 1970s. Rapid onset, these are all the things we want. Short duration of action, low side effects. Basically, it actually decreases ICP a little bit. It actually gives you a little bump up. It's a little sympathomimetic, so it's not going to be a negative inotrope or chronotrope. In other words, decrease your cardiac contractility or cardiac output or your blood pressure like propofol and some of the barbiturates do and so forth. Now, the drugs of this, in adults generally don't get hung up. We have to do our protocol, but it's 0.3 milligrams per kilogram, and you have to sit there and figure it out. We used to do up at the university, we had them drawn up, bagged, ready to go, 20 milligrams for an adult. If every adult's 70 kilograms, 0.3 is 21, 20, just boom, bang. Okay, let me see. It's very potent. Usually acts within 1 arm to brain circulation time. I don't know if you've ever given anyone etomidate, but it just knocks them out pretty much immediately. Okay. Stimulates GABA receptor. We just talked about that. No, what's going on with the slides, sorry. Decreases cerebral oxygen consumption by 45%, cerebral blood flow 34%, decreases ICP, minimal change of cerebral perfusion pressure. It's very good in trauma, it's very good in head injuries. It's just a winner. Quick onset, short half-life, bam. There's some side effects, nausea, vomiting, that's alleviated with the paralytic agent, and so forth. No absolute contraindications. Okay, let me just keep going here. As far as Versed given as an induction agent, that's what used to be given back in the day. Certainly, I used to give it back in the day, we all did. The problem with it is when they studied patients given the Versed and then the paralytic agent, they found that most of these patients were awake when they got the paralytic agent during RSI, so Versed not recommended. Then they said, well, let's bump up the dose. They needed to bump up the dose instead of 0.1 milligram per kilogram to like 0.5 milligrams per kilogram. And then you get loss of air, reflexes, you get hypotension and other things. So certainly Versed is falling out of place. So let's go on with these slides, I apologize. Let me see, I just talked about this, I don't know what's going on. Okay. All right, we said that. Okay, let's talk about paralysis real fast. Okay, the first paralytic agent was Kawari, ether, I'm sorry, in 1842. 1932, Kawari came about. I think that was the one on Bugs Bunny with that little devil guy who shot him with the blow darts. I imagine that was Kawari, I don't know. And then succinylcholine came in the 1950s, and what's interesting is it has been the drug of choice for paralytic agents since the 1950s. There's no other drug that has been around as long as succinylcholine. It still is the gold standard. Why is that? Well, it's quick acting and it's short lived. However, there's a new one on the horizon that has a reversal agent we're going to talk about just real fast. Okay. So what happens? The normal neuromuscular transmission, let me just, is right here. This is your, you can't see that, can you? Yes, there. Let's do this one. This is your neuron, and this is your muscle. This is acetylcholine right here. So this gets activated. Hey, arm, go up in the air. What just happened? My neuron went from my brain to my spinal cord, and then it's my spinal cord neuron after the synapse goes all the way down the arm. One neuron to the whatever muscle lifts it up. Actually, a whole bunch of agonist muscles. But anyway, it goes up. It secretes from an action potential acetylcholine, which goes and binds nicotinic or acetylcholine receptors, and it causes a depolarization here of the muscle, and it contracts and lifts the arm. Well, succinylcholine is it just mimics what the body does, and it's two acetylcholine molecules bound together in a covalent bond, and it just binds, but it doesn't let go like the acetylcholine does, because acetylcholine gets metabolized so quickly by an enzyme, acetylcholine esterase doesn't really matter. But the succinylcholine stays on and basically causes tetany and wears out, puts the muscle in refractory period and you get paralyzed. That's why the first thing that happens is they contract everything because it's acting like acetylcholine does, but it doesn't let go as much because it's metabolized by different enzymes in the blood. Anyway, that's how it works. I'm not going to go into too much. That's just kind of a electron microscopy picture of it. There's the neuron, there's the muscle, there's the junction, there's the acetylcholine. Here we go, bound, contract, not let go, paralysis. There you go. It's a beautiful thing. There's it is. How can I beat that to death anymore, huh?
Dr. Lafferty,
Yes.
you have one comment up there.
Good. Let's see, slides aren't working. Which one?
The last one.
Dr. Lafferty, about how he feels about the Versed and dilaudid cocktail for each drug mixed and given. How he feels about the Versed and dilaudid. Is this post-intubation? Is that, you know? Is this post-intubation? Pre. No. There would be, RSI is a two-drug, RSI is a simple thing. It's not, we shouldn't complicate it. It's two drugs. It's an induction agent and it's a paralytic agent. That's it. There's no lidocaine for head injuries. Those studies stink. They didn't mean anything. There's nothing else. It's an induction agent and it's a paralytic agent. No need for dilaudid, no need for Versed. They last too long. That's just it. So I'm answering that. It's a good question, but it's just a two-drug regimen. Induction and paralytic. That's it. Okay, good. My goodness. What's going on here? Wow. All right, we talked about that. Okay. And again, during all this, we can't induce any hypoxia. It's the same slide. We just want to beat that one to death. Okay. I paraphrased a lot of these slides, so I'm just jumping through them. Okay. One interesting thing, succinylcholine, it's actually broken down by an enzyme, pseudocholinesterase, that if someone has cocaine on board, that cocaine is metabolized by the same enzyme, so you can have a little lasting effect of succinylcholine, and we should see that in Philly somewhat. The other thing is in Philly at some point, the people were lacing their heroin for a while, and they were putting RAID and other organophosphates in their heroin, I guess to make it bigger amount. But the other thing they were doing is by doing that and using it with cocaine, they knew, and I don't know how these people know this, they knew that the RAID, or the bug spray, was an organophosphate inhibitor. It inhibited the enzyme that breaks down cocaine. So they were coming with organophosphate toxicity, cocaine toxicity, and if they got intubated, the succinylcholine lasted longer. So just kind of a little, okay. I think these slides just went. Okay. You can store sucks for 3 months at room temperature, and you still has 90% of its potency. Okay. Okay, there we go. One last thing about succinylcholine. We're beating this drug to death a little because it is powerful, so you have to know some of the side effects. About 3 per 10,000, or 0.03% of the population, has a deficiency or an absence of pseudocholinesterase. So if they have deficiency, they're a heterozygote for this condition, it will double the half-life of succinylcholine. If they have if they're a homozygote for it, this could last for hours. They'll be paralyzed. Just a kind of like a thing just to keep in the back of your mind. Okay, I don't know what's going on with these slides. Okay. The other thing is masseter muscle spasm is a very rare complication. I've seen it once. Okay. Okay. So beat that to death. One slide on a new drug. Don't know how to pronounce it, so I won't. This is being used in Europe, and it's under a phase 3, about to be a phase 4 trial here. Rocuronium, it's a paralytic agent I didn't talk about. This is going to have a lot of bearing in the future of airway use, pre-hospital and hospital, because this drug actually is a reversal agent, the first one for a paralytic agent, a true reversal for rocuronium. We don't use rocuronium now because it hangs out for at least 30 to 45 minutes, probably more like 30 minutes. But this is going to be an interesting thing when it hits the States and finally gets approved. This will be a reversal agent for a paralytic agent, just an FYI. Okay, how do we know if the tube's in? Back to some good stuff, not the boring pharmacology, I apologize. So you can pray, right? Or what's the gold standard, guys?
Sonography.
Right. Whatever invasive tube. Now we're kind of off the device here. Interesting enough, there was what about the vapor trail? The vapor trail doesn't work. Why not? Because Dr. Jack Kelly in Philly, again, intubated dogs in a dog model in the lab, in the emergency department, and they found out that there was condensation. Every time they intubated an esophagus, 100% condensation. Cool. Then they intubated the tracheas, and they found out there was 83% condensation at some point in the trachea. So you can't use condensation. That's all. Simple study. Okay. So end-tidal CO2. By the way, that is an endotracheal tube placed in, and this was back before the end-tidal CO2 days, which is now the gold standard. It was an esophageal intubation, and the patient came in hypotensive with a distended abdomen. This was a cool case, not for the patient. Well, they did okay eventually, but anyway, very distended abdomen, and it was markedly like the blueberry girl in Willy Wonka. I mean, just across the room distended. So it was an esophageal intubation with a gastric perforation, and they had a tension pneumoperitoneum, not a pneumothorax, a pneumoperitoneum. So we had to decompress the abdomen to go to our gastric rupture. So certainly end-tidal CO2 has been a great thing, and certainly it's the gold standard. Just real fast, I'm not going to beat this to death, just like the oxygenation came from the alveoli, went on the hemoglobin, delivered it off to the tissue, the same car picked up a carbon dioxide molecule, took it around to the venous side of the circulation, to the alveoli, and dumped it out into the alveoli. Hey, now it's pretty much like the venous or the pulmonary capillary venous carbon dioxide is similar to the alveoli carbon dioxide, which is pretty similar to the tissue carbon dioxide. Now we have a way of monitoring, is this tube in the esophagus where you wouldn't have this circulatory setup, or is it into the airway? So end-tidal CO2 is very good. It actually depends on cardiac output too, as far as a push. So end-tidal CO2 is something not only you can use to see if a device is where it needs to be or not, esophagus versus the airway, as far as CPR and other modalities following cardiac output. Okay, what about the What about the cardiac arrest patients as far as airway management, okay? What have we learned over the years on a cardiac arrest patient? Very recently, everything trickles down slowly.
It's more about circulation than the actual airway.
Absolutely. We used to jump on airway, now it's a cab. I know we all know this now, but we're still seeing some reports, again, pre-hospital and hospital, where people are still treating as an ABC thing, and we're really hurting the patient's chance of having a significant morbidity or decrease in mortality with that. It is a circulatory problem. And why is that?
There's enough oxygen in the bloodstream.
Someone here just drops right now, a drop. And you check the reversal things, your sugar and arc and all that, and you drop. And you throw them in a monitor, and their pulses VTAC, BFib. Why are we not jumping on the airway?
Already oxygenated.
They're already oxygenated, right? They didn't have a lung arrest. They had a heart arrest, so the lungs still working. Okay, good. The other thing, why the emphasis is on the airway, on the circulatory situation too, and this is not a lecture on cardiac arrest at all. This is a lecture on airway, but I think this airway topic ties into the cardiac arrest, and this is one of the things, by not doing it, you help the patient, and I think that's where it goes into the cardiac arrest model. Is if you stick an airway in there, you're going to increase in intrathoracic pressure too, which is not good for cardiac output and for impedance of blood flow, because it's all about coronary perfusion pressures. The other thing is, if you're screwing around with an airway in these patients, you're going to be less apt to be hands-only CPR. And right now it's all about forward push, trying to get that cardiac output of 25% as much as possible as normal. You have, and 25% is a great situation, getting your coronary perfusion pressure up, because the rest of your body is shunning blood to your brain and to your heart. And if you do hands-off CPR, even for 5 seconds, you're decreasing your coronary perfusion pressure, and you're not helping this patient at all. And it's going to take you a little while to beef up your coronary perfusion pressure. Because remember, when you push in, you're not getting any blood flow to the heart at all. You're pushing blood out of the heart into the aorta. When you recoil, you're allowing back pressure into the coronary arteries. When you push out, you're getting into the brains. When you full recoil. If you dick around with an invasive airway and you increase and you're getting more hands off time, you're taking away that entire coronary perfusion pressure, and you're also increasing intrathoracic pressure. So this is not a lecture or discussion, I should say, on cardiac arrest. However, this is one of these times you don't want to spend a lot of time on an airway. Now, I'm not going into anything controversial here as part, but certainly this is a beautiful spot for an eye gel, okay, or some quick device, or no device. Okay, that's all we're going to talk about that. Okay, so I'm going to skip some of this. We're going to skip some of, well, there is one study I'm going to talk about. Individuals with no endotracheal intubation. This was a study that looked at, what was this one? Looked at a retrospective study, looked at ROSC, return of spontaneous circulation, and they looked at endotracheal tube placement. Okay, so they analyzed from 06 to 08, 1,100 patients, almost 120 being discharged from the hospital. Pretty good, right? About just under 10%. So it's where everything shows where it normally is. Individuals with no endotracheal intubation attempt, okay, were more than 2 times more likely to have a return of spontaneous circulation as compared with individuals with 1 successful endotracheal attempt. That's not saying, hey, it's bad to stick a tube in someone. It's just talking about the physiology, what we just talked about right now, and the importance of continuous hand CPR and coronary perfusion pressure. You're taking away from that, and you're increasing afterload. Okay, it's just a big deal. This is one of those things we did not recognize years ago that we recognize now. How about individuals with no endotracheal tube attempt? They were over 5 times more likely to be discharged from the hospital alive compared to 1 successful attempt. Okay. So this is not a study that medics or physicians can we intubate? Should we? This is one of the ones that you have to look at that. Okay. Okay, I'm going to skip that. Another thing.
Trauma patients.
Okay. to work on Coco with acting. Some literature states that no difference in survival whether the pre-hospital endotracheal tube is in the trachea or the esophagus. Okay. Again, why is that? You have trauma patients, you have half of them sticking them in the trachea, some in the esophagus. No, you would think, well, my goodness, if it's in the trachea, now so prolonged hypoxia, induced hypoxia, hyperventilation, all these things. Obviously, in the ideal world, if you can get a tube in and almost immediately have no hypoxia, you're going to have a different outcome. But there's so many confounding factors that go into this. Certainly in faraway rural areas, you have to certainly relook at this as far as training and other things go, okay? This was a position statement that was placed out on an expert panel, and this is very recent. And these are some pretty hard hitter authors in this expert panel as far as trauma and airway issues. And I'm just gonna read a couple of these lines. There's no prospective controlled trials available to provide definitive conclusions regarding the efficacy of paramedic in severe traumatic brain injury. Therefore, they can't even make a recommendation. This is such a gray area. I think in a nutshell though, you have to look at transport time, how close you to the trauma center, training, other injuries and so forth. So this, this is all being sorted out as we speak, and there's different studies showing different things, but certainly many of these studies with poor training, hyperventilation, induced hypoxia, it's not the outcomes we initially thought. And not only some of the studies showing there's no difference in morbidity and mortality, whether you stick it in the right hole or wrong hole, there's actually hurting some of these patients. And again, it's just because of induced hypoxia, hyperventilation, and training and so forth. Okay, so we're kind of getting near the end, but not at the end. Is everyone good? Keep going. Question?
There just seems to be a trend when it comes to going back to RSI. Reasons to not do it, or just be careful when you do it. When you compound that with the fact that we're using Versed right now, because we don't have the Tomidate, I can almost look at any patient and find one reason to not do it.
Yes.
Is there a telltale, hey, you have to do it in this situation? Is there one type of patient where, hey, yeah, even if you have just Versed and, prolonged hypoxia and all that stuff, it needs to get done? Can you think of one offhand that we could apply that to?
I think this topic, and you're asking a great question, obviously. I'm going to answer that at the end. I don't mean to defer it. I just think I have a few more things to talk about, okay, and then we'll answer that question. As far as Versed and Tomidate goes, though, the reason we don't have a Tomidate now is a drug shortage, and that's not just local. That's obviously statewide. And we just had Dr. Joe Nelson here. They're dealing with it hard in Tallahassee. And it's a national problem too. Versed is not the ideal drug, so that's one issue. As far as when you go, and I think in the beginning, sometimes it's hard to know when you go from a level 3 airway management to a 4 to a 5. It's hard out in the field. It's hard here. A lot of times when things don't make sense, you can't understand them, you can't figure, it's because it's controversial and gray. Everyone's trying to do the best thing by the patient. Certainly, no matter what we do or don't do, the thing that we don't want to happen is inducing hypoxia. So if they're hypoxic, we want to reverse it. And this is just the things that Corey was showing. The basic head maneuver, a conduit, a non-invasive, a supraglottic airway. And then as far as this patient's deemed to need a more definitive airway, I'm just going to save that for the end because I have some more slides about that, okay? But again, not to beat this to death, we cannot allow a patient to be hypoxic. Certainly we can't induce hypoxia. Okay. So just raise your hand at the end of one. Okay, so we can't ignore technology. So just like we used to use the stars for navigation, and if anyone here flies airplanes or anything, they used to get up in the air and pull out these charts and do dead reckoning and realize so many seconds at this speed be here. And God bless them, but hello GPS, right? Same thing as far as, this is just a few slides on video laryngoscopy, just real quick. Basically, the studies looking at video laryngoscopy compared to direct laryngoscopy have a much higher success rate, much less training needed for this success rate. and less complications. And this is studies across the board. I just included a few of them. You can see medical students, novice anesthesiology, residents, initial success rate has been either a third or 2/3 on first time, second time intubations. There's studies out there showing, well, how many tubes, this is with direct laryngoscopy, not the fiber optic stuff. How many tubes do you need to do before you're even licensed to go out there and tube someone in a training program? They're saying some people 50, maybe 60. You know, that's hard to come by now. People are getting tubed less. There's supraglottic airways in the operating room. There's nursing anesthetist students, physician assistant students, anesthesia residents, and so forth. So it's getting harder and harder to crack this 50 number. There's no doubt about it. Okay, so video-assisted techniques offer the advantage of abandoning the need for alignment of the oral axial, the pharyngeal, and the laryngeal axial, which is really most of the challenge. Quick story, my first time I've intubated anyone. I had no hospital experience, no medicine experience. My first day I was a doctor in my residency. My first patient, first day doctor, first patient, I was doing anesthesia. We had to do a rotation. And the patient had 2 teeth, this old lady, a Gomer in Philly. And my first one, yeah, I know how to do it. I was so excited, I just ready to bust out, and I popped it in her 2 shot across the room. So the guy never let me tube any patient my entire rotation, the entire month. It was all supraglottic airways and so forth. But obviously there's some challenge to learning the technique, lining up these axes and so forth. Okay.
50% tooth loss is high.
Yeah, that's right, 50%. But I kept 50% of her teeth. So anyway, this is the glide scope, real fast. This is a couple articles, real fast. Everyone's tired after an hour. Certainly my brain is going. They compared the success rate of direct laryngoscopy, old-fashioned way, metal, by personnel untrained, nurses, medical students, paramedic students. They gave them a half-hour mannequin. They took them to the OR, okay? And they said basically 200 patients were divided, and they let them tube either direct laryngoscopy, real patients after just a half-hour training, or a fiber optic. And the success rate for direct laryngoscopy was 51%. But for video laryngoscopy first time, 91% success rate, and the time was much less. And the conclusion was that the glide scope, in this case the glide scope, it could be any video assisted device, it's much easier to do. You can go around those lines, essentially. You don't have to line the lines up, you go around the lines. Much easier to do where even novice is much less training. With a success rate of over 90%, glide scope system might be a significant improvement for standard tracheal intubation performed by medical personnel who learn how to intubate or perform tracheal intubation only occasionally. It's a back pocket thing. And you're right, it's being used less and less, and it should be. But when you need it, it's good to have the skill. I'm not going to go through all of these studies right here, but basically in obese patients that were very difficult to intubate for bariatric surgery, they compared direct laryngoscopy with metal blades compared to regular direct fiber optic laryngoscopy, much improvement. They looked at cervical fracture patients or inline cervical immobilization patients in the OR. Fluoroscopy, they were looking how much the spine moved, fiber optic versus direct laryngeal or the old-fashioned metal. Much less cervical motion at C1, C2, and C3, C4. They looked at that, and there's a cervical fracture there. Doesn't really need to be here, but that's a C2 fracture, the dens on a sagittal, and there it is in a cross-section CAT scan. This was looking at bariatric patients, and one of the things when anesthesiologists operate, they often say, hey, if you ever get operated again, I want you to tell the anesthesiologist you were a difficult airway. Well, this was a chairman of a very large multi-hospital program. He said, hey, we're using a glide scope now, and everyone's easy. We need to come some way to tell them that these patients need to tell the next hospital they might not have a glide scope or video assisted, that I was used fiber optically, I might be a difficult airway. He was actually concerned enough that it was so easy in his difficult patients. He was talking about putting out a letter. Let me see here. I'm not sure what this is, I forget. Is this going to work? Oh yeah, there we go. A little slow. This is a crazy person.
No, you're not.
Yes, he's going to do it.
So we're in a lecture, Joe.
Oh wait, we have dial. Is this like dial-up speed or? You know what? We don't have time now.
Make it, Keith, make it full, make it a little more screen and it'll go faster.
Oh. No.
Go, go.
So the music was definitely the key part. So only someone crazy would do that. So last night we were bored. I wanted to test this.
Nice.
Say ah? Okay, okay. And then right over here again.
Isn't it great having students? Okay. So I'm just gonna.
That's screaming for ridicule.
Okay.
Was that Chris that let you do that?
Yeah. So this is pretty much the end of our thing here. I just want to go through one scenario, okay, and then we'll open it up to ending questions. So I'm going to ask for not Corey, thank you though, 2 paramedics to come up to the front. And don't worry, the whole world's watching. Okay. So
I sound real nasally. I'm gonna sound bad.
okay, so we're going to go through some real quick scenarios, okay? Like lightning quick. So we have to listen because we're going to do this in 2 minutes. Ready? And by the way, I have nothing planned right now. I'm just going as I'm going. Okay. You go up to a patient right now and they're unconscious. And by the way, that's the patient. A 33-year-old calls EMS taking his wife's Klonopins and slashing his wrist. Why is this not working? What do you do?
That's him.
That's him.
Laying on the ground.
Okay. And by the way, just for the ease, there's no trauma. He was laying down when he took him. He's lazy.
Alright, come on. Check level of consciousness, alertness,
No,
looking
that,
out.
no.
This is him. Alright. Do all, see if he's breathing.
Good.
Check for breathing.
Okay, so how do you check for breathing?
Head tilt, chin lift.
Okay.
No trauma.
Look, listen, feel, right? You want to do look, listen, feel. Is there anything he's unconscious that you want to, and there's no right order right now, but is there anything you want to quick, because you always want to reverse in life what you can reverse. Is there anything quick that you might be able to check? Anyone in the room?
Blood sugar.
Okay, blood sugar.
Stop the bleeding if it's bad.
Right.
Slit his wrists.
Okay, I'll just say there's minimal. It's one of those, you know, I want to kill myself, but.
You did it the wrong way.
Right.
I think that's a real
So, and you give him Narcan, okay? Check his sugar and give him Narcan. You want to reverse what you can reverse. So you look, listen, feel, you're not hearing anything. Someone's putting one on a monitor. You hear some airway noises. He is breathing, but he's a low Glasgow coma scale, but
Okay.
So
what's that lung sound like?
well, right now we have an airway issue.
Okay.
The whole thing is you want to go, by the way, I'm not putting you guys on the spot. We did not rehearse this, I apologize. This is just a teaching form, that's all it is. And I learn when I do this, and we all do. So you want to go through A, B, C, D, E, and all this. But you put him on a monitor, he's not in VTAC, VFib, by the way, because that would change it to the taxi cab. But that's not happening right now, because we just mentioned that before. That's not part of it. So, okay. So look, listen, feel, reverse, we reverse, can't. And he's got some airway noise. So what does that mean with airway noise?
Just a little bit.
Partial airway obstruction.
Okay.
Upper airway noise?
Yep, you hear it in his neck.
Okay, that's all it is.
So generally when something's
Brett,
wrong with
Brett.
A, you want to fix A. You almost don't want to move on to B. So if you have a problem with A, you need to fix A. So you have noise in the upper airway, someone who's having an airway issue. So Corey showed us some different steps and levels of airway management. So which one would you like? What's the assumption now, anyone?
Head
Okay. The assumption is that this is,
partial airway.
right, the base of his tongue is lying against his anterior pharyngeal wall, right? So we want to lift his hyoid bone because that's what the base of the tongue attaches to. We want it up in the air. So go ahead and do that. Okay.
So we're gonna, he was Okay.
Okay.
Was neutral, now he's gonna put him in.
Okay.
Head tilt, chin lift.
And there's no cervical spine issue in this patient, don't forget. Okay, so you go ahead and do that. Doesn't work. We're gonna make this quick, and I'm gonna do most of the speaking here, so, okay.
All right.
So what else? Doesn't work.
We're gonna do a nasal trumpet.
Oh, well, he's, right. Now, if he was conscious, you wouldn't do the oral pharyngeal, the OPA, because it can induce gagging and vomiting, right? So nasal trumpet's a great choice, so, okay.
Or an OPA, since he's
Okay.
completely out.
All right, so pick one. I'm a fan of nasal trumpet, but there's no, but go ahead. So you stick a nasal trumpet in him, or OPA.
We did an OPA.
Okay.
And then we're gonna check for if the tongue is lifted off the back of the throat.
Okay.
So is it still making
Right,
noises?
because one thing Corey said, and it's very sound, and I've seen this, you can actually make an airway obstruction by taking that OPA and pushing the base of the tongue deeper and more against the anterior pharyngeal wall. So you do that, not working.
Okay.
Now what's that?
We're gonna see if there's an airway obstruction.
Okay.
It could be bronchoconstriction, it could be, numerous things.
Okay. Well, we still-
So Klonopin, it could be an allergic reaction, it could be small.
Now, he's on a monitor now, right? We didn't talk about that. That's one of the safety nets that has to go on first, besides going through your A, B, C, D. He's on the safety net. Safety means cardiac monitor, pulse oximeter, and part of safety net is reversing what we can reverse. We didn't go through it. So safety net is checking the sugar, giving Narcan, cardiac monitor, pulse oximeter. And I can tell you now, his pulse ox is 82%. Does someone have a question?
Yeah, question, they want to know respiratory rate, SpO2, and CO2.
Okay, no, it's a good question. His respiratory rate is 32 and his pulse ox is 84%.
Brian Kirkland has that question. Brian Kirkland.
And someone put up their
You
IG.
want to put 100% O2 on and while you're prepping a new airway.
Okay, you want to put a,
Hold a tight seal, doesn't cause it.
Okay.
Yeah, just to get the pulse oxygen.
okay, so let's do that. That's a good idea. So we already went through level 1, head positioning, level 2, a conduit not working. So now you keep the conduit in there though, and make sure it's in the right, you want to keep that open. So, okay. So he is 84% still.
Okay, we have the bag on now, creating a seal.
Good. He's still 84%. Now remember, guys. Okay. Now, why do you bag him now? Because of the curve, right?
Below 90.
Once you get below 90%, and this is the SAT here, you drop severely. So you want to get them above 90, that's our number. And by the way, a PaO2 gaseous is the upside down of 9. It comes out to a 60, a PaO2, but that doesn't really matter. Okay, so you go ahead and, so you're bagging. So now he's up to 88%. And by the way, your partner, when you're doing this, is checking the rest of BC. So he's got bilateral breath sounds, okay? He, circulation, he's got strong pulses, his blood pressure is good. I'm keeping this for the lecture safe. And when we do this scenario throughout the year, we change it up. We make him hypotensive. We go through a secondary survey, head to toe. But we can't leave the primary survey here because we have a problem. And our problem is oxygen, and we don't want an oxygen problem. If they're hypoxic, we have to fix it. And if they're certainly not hypoxic, we certainly don't want to induce hypoxia again. So, okay, so what did I just say? What's his pulse ox?
Pulse ox is 88%.
Yeah, 88.
Still coming up.
Okay, so he's 88.
So it's coming up.
Someone said iGel.
It says IGL, keep ventilating BVM, keep bagging, not vomiting or suction ready.
Bag, pulling suction like you said.
Okay.
Have it ready while your partner's prepping the eye gel.
Good, suction.
Put your gastric tube in your eye
Okay.
gel, put the eye gel in.
Why don't you go up and give them a hand? Seriously, go up.
All right, Samantha.
Samantha? She seems like she's iGel expert anyway. So go ahead and get the iGel.
Easy.
Okay, so you're bagging, and I have suction, and you're prepping the eye gel and putting in the gastric tube. So stop bagging for a second. Pull the mask off. Gonna suction 10 seconds. Pull it out. We're clear. Gonna put it in the eye gel. Okay, bag until he's done with the eye gel.
We normally don't tell him twice, so don't worry about it.
Okay, so remove that. Remove the BBM. Going to pull out your OPA and put in your eye gel. Which in a real patient takes about 2.5 seconds because it goes in a lot easier. Okay, put the BBM back on. Pull the mask up.
She should be your
Continue
voice.
to bag.
Yeah.
Watch for suction. Continue to bang, and my other partner is going to secure this eye gel.
Good. So the
We'll go
patient,
from there and we check our pulse oximetry to make sure it's over 90. Are we over 90?
you are at 90% right now.
Okay. In the process, we want to make sure that we get capnography on.
Good. So your end tidal CO2 looks good. You have a good waveform. And at this point, you would transport the patient. We have our 90%. We secured an airway. That's one scenario. Let's keep going with this scenario. The patient starts vomiting, becomes totally unconscious, stops breathing, and pulse ox drops into the 70s. Okay?
Becomes completely unconscious without a pulse?
No, has a pulse.
Okay, well, we're getting, it does have a pulse.
Does have a pulse.
Okay,
Well, I should say less conscious. Let me think of it. Less conscious. Glasgow dipped even lower. But he has a pulse.
You want to make sure that you suction immediately.
Okay.
And you're going to check the airway to make sure that it hasn't become dislodged or compromised. You can use your stethoscope to check breath sounds and chest rise.
Okay.
While you're still bagging. You want to make sure that you clear all that vomitus out.
You
so
cleared the
that
vomit with
full
suction.
aspiration.
Good. You cleared the vomitus with suction. You have breath sounds. They're junky, but you have breath sounds, and you just can't maintain a pulse ox out of the 70s now. Okay.
You're going to consider intubating.
Okay.
You're going to continue to.
Me personally, this patient, I would intubate this guy.
Okay.
I wouldn't mess with this eye gel because
Well, no,
and stuff, you know? I mean, I'm asking.
Yeah, no, I think it's.
Start using this eye gel first, or me personally, if I had this patient, I would intubate him.
Yeah.
Protect the airway.
Yeah, I think it's good to. I didn't say this initially. The patient had a gag initially, and it's good to do this in a. Think about it in a stepwise fashion. It's what we should do. At this point, though, you said consider an endotracheal intubation.
Consider
Okay.
intubating, have a medic or another person
Okay.
to start to set up the intubation
Okay.
set.
Okay.
Pre-oxygenate your patient for 2 to 3 minutes.
Okay.
While the
And what are
intubation's
you
being
doing when you're? And this is excellent, all of you. What are you doing when you're pre-oxygenating this patient? Doing a nitrogen washing out. You're filling up the alveoli. Now you're above 90% right now.
So
I know this
you
isn't.
can stop bagging and you just
Perfect.
make sure that you have a really tight seal.
Okay.
And 100% O2.
Okay. Okay. So you're doing that, and then someone is drawing up 2 drugs, right? An induction and a paralytic, 0.3 milligram per kilogram, 70 or 20 milligrams roughly in the sucks, and we're going to get them ready. Now it's been 3 minutes. You're going to give the induction. You're going to give the paralytic, and you guys want to take a look?
You're going to pull the.
Okay.
You're going to pull your BBM off.
And what happened if the pulse ox dropped at any point less than 90?
You're going to stop bagging.
Okay. You're going to start bagging. Yeah. Okay. So, great. Okay. So go ahead and then just open this up.
You got 2 right around there?
Here you go. Right here. Okay. Okay. So go ahead. That's it. Just cock. There you go. Just cock that up right there. So that's okay. You don't have to. I mean, you can, but you're right there. Okay. Okay. That's fine. So that's it. Very good, all of you. Very good. Great job. So a good way to look at airway management is just look at it in steps. Look at it and think about it, and think about every piece, every modality. Okay. It's a good way to approach. Always reverse what you can reverse. We can't tolerate, again, hypoxia. We can't tolerate it. We have to fix it when it happens, and we certainly can't induce it.
Something I convey to our people all the time is I don't disagree at all with what Brett said. And again, I agree totally. You go through the steps, and those are all steps of consideration. You got to consider your own skill set at each one of those steps. Are you good at this? Or are you not good at this? My people expect me to say sucks, I say it all the time. Do you suck at it, or are you good at it? If you are skilled at that procedure, then I too, I would go to an endotracheal tube. But you know, if your success rate is 3% on a good day, I don't want you going there. You know, so I mean, it's not a one-size-fits-all approach. You got to consider your own skill set, your own comfort level at every decision point.
And this talk it goes from basic airway management to complex airway management, and it's all the literature, whether it's an I-gel, whether it's an NPA, OPA, they all take training, learning, practice. They all do. Some are more complex than the others. Certainly all the literature with a lot of the RSI, drug assisted, it comes down to education, continual education, getting time, intubating. Certainly there's a group of people that believe that video assisted equipment is going to make a bridge for lack of training. That's what the studies show. And we're going to see what some more prospective studies show. But whatever your comfort, certainly if you're not comfortable placing a tube in someone, you can induce harm by inducing hypoxia. But it's still good to think about everything in a stepwise fashion. And the big thing though, I can't say it over and over and over, all the medical directors in this area, locally, statewide, nationally, all the literature says hypoxia cannot be tolerated because we've been ignoring hypoxia for years. And that was really the big issue with the negative outcome studies that we've been seeing. Why were they negative? Probably because it comes down to training and practice. So, but anyway, this was not a lecture per se on any one modality. It was just about the anatomy of basic airway, the physiology of oxygenation, tissue level, alveolar level, and how to think about airway management. The other thing, there's nothing black and white in medicine. That's why it's an art. That's why we practice all the time. But we just do the best we can do. We learn, we educate, we teach, and we just do the right thing by the patient, and that's the best thing. So, hope that answered your question. If it didn't, just say it did.
I was just asking just because
yes.
We had a scenario a couple months back.
Yeah.
Where, I mean, it was a real call, and it was something similar to that.
Yeah.
To where everything in my mind was telling me this guy needs to be in. It was drug overdose. This guy needs to be intubated. Needs to be intubated.
Certainly the statement, we cannot tolerate hypoxia, you have to look at that statement. And if you have a skill that can reverse hypoxia, you know, it needs to be used when it needs to be used. And that's why we teach it, practice it, go over it, whatever that skill is. You know, we have to reverse hypoxia. However, the days of just picking up people and doing it because you can, and you know, the studies showed that there was not good sequelae and bad outcomes without proper training, education, patient selection, and so forth. So certainly not wrong in doing it, and that's why we teach it so much and talk about it and educate. It's just when to do it, who to do it, and how to stay on top of it. Okay. And use, you know, other modalities when you can, and then you can't, then you know, you have to reverse that hypoxia.
You had mentioned in your scenario with the I-gel in place that the O2 saturation dropped to the 70s. You guys are switching from an I-gel procedure to intubation. Is it still appropriate for the patient in the 70s to do a nitrogen washout? Aren't you not at that point where the reservoir is even close to being full?
No. At that point, I would probably leave the I-gel in personally and use that as my mask, because it's really a mask, as Corey showed. Right. It's kind of pushing anterior against the glottic opening, and just use that as my mask. Instead of putting a mask on a face, it's almost like putting a mask around a larynx, and just do the best you can do to oxygenate that patient. Yeah.
We had a patient a few months back.
I think you have to speak up.
Sorry, we had a patient a few months back where
we all want to hear it because we like your voice.
We had a patient a couple months ago. It was a full cardiac arrest. We walked in. We went through the OPA. We did the.
Good.
We used the I-gel. We had great success with the I-gel, but then this patient had a lot of vomit,
yes,
thick gunk. We were suctioning constantly. We did the parameters. And then we had to use a second I-gel because that first I-gel got completely gunked up.
Yeah.
We went to use that second I-gel. That airway was already compromised. It was so wet that that second I-gel didn't sit well.
Yeah.
So as we were trying to deal with that issue, we were prepping the innovation kit.
Yeah.
Ended up innovating our monitor did not record anything. We had capnography in place, and all of our tools, we were getting good readings, oxygenating the patient, but that was a scenario where we ended up having to intubate because all of our other airway adjuncts were failing. And unfortunately, the patient didn't survive, but all of our airway techniques worked
Yeah.
in the end
Yeah.
with the innovation. But the agile does work to a degree, but that was where I was stating where, excuse me, when it gets to be a really wet, funky airway,
You're going to lose your
you have
seal.
to move
Yeah, you're going to lose your.
innovation.
Absolutely. And that's why we learn all this. We want to take care of the patient. You know, forget all procedures, policies, no matter where you are, what side of the fence, how you look at the literature, it's all the same outcome. It has to go back to the patient. We have to do the right thing for the patient, which is about oxygenation. And many a time we were inducing hypoxia, which is the wrong thing for the patient. The same side, you know, the different sides, we can't tolerate hypoxia.
My
So
question was more geared towards the process of the nitrogen washout that you speak of. The 3-minute process,
Yeah.
with O2 saturations already decreased.
at that point, you have, if you can't get the oxygenation up, and remember those original slides, there might be fluid in the alveoli, there might be diseased alveoli, those initial Netter drawing slides. You might be doing the best you could. There could be vomitus in the airway. At some point, I can't oxygenate this patient. It's like a drowning patient that comes to the hospital. You can't oxygenate them. They're intubated. They're on high peak pressures. They're on a high FiO2. You can't oxygenate them anymore. Doesn't mean you stop. Then you move on to something called ECMO, where you get an artificial lung machine, and you have a little bypass through that to help them. So if that's all you can get them up to with the modalities you have at hand, at that point you have to just say, I only can get them to 74. I tried. I can't. At this point, I'm going to, move on and try a more definitive device.
We get out there,
But you have to try to get them up.
Yeah, I mean, you get bad CHFers.
Yeah.
And their O2 set stinks, it starts, we get there, EM them, try to get them up, you can't get them up, they're drowning.
Yeah.
And just, that's what I'm saying, this guy here,
Yeah.
as big as he was, I would be like,
Yeah. Well, this is a teaching model. It was used to go through the different levels and thought process of reversing what can be reversed on unconscious patient, going through the stepwise of airway issues. And, things change in the real world of gray. But again, I keep going back to it, is, we're all trying to be better. We're trying to do better. We're trying to take care of the patients better, all of us. And we're scrutinizing everything for better patient outcome, for education, for training. So we just can't tolerate hypoxia, and we can't induce hypoxia. So, and again, Corey says it has to match our skill levels too. And we're working on that. We're working on every month. We're working on that. So, okay. Good.
Sponsored by Mountain Dew.
Sponsored by Diet Dew. Do the do.